Good morning, everyone. I'm here to present our study entitled Insulin-like growth factor reflect muscle and bone health and determine complications and mortality in decompensated cirrhosis. Growth hormone resistance with low circulating IGF-1 level is common in cirrhosis, and this severity of growth hormone resistance parallels with the severity of the liver disease. IGF-1 levels have been linked with the poor prognosis and cirrhosis and sarcopenia in cirrhosis patients. However, the association of growth hormone and insulin-like growth factor on complications and development of new onset complication is not known. So the aim of this study was to explore the association of GH-IGF-1 levels with sarcopenia, frailty, bone health, complications, and prognosis in decompensated cirrhosis patients. This was a prospective cohort study in which we included 172 patients with decompensated liver cirrhosis. At the enrollment, we measured the levels of growth hormone and IGF-1 through CLIA. We assessed the sarcopenia by calculating skeletal muscle index at L3 vertebra using the TPCT abdomen. And bone health was calculated through the DEXA scan. Frailty was measured through the liver frailty index. At the follow-up, we noted the development of complications and prognosis at 90-day and 180-day follow-up. We also assessed the dynamic changes in the GH-IGF-1 levels at the 90-day follow-up and explored their association with the development of complication and prognosis at 180-day follow-up. These are the baseline patient characteristics. Median age of the patients was 47 years. Majority of them were male. Most common etiology of cirrhosis was alcohol related. Majorly the patient belonged to child B and child C class. To analyze our data, we divided the patient into three groups based on the IGF-1 levels. Low IGF-1 with the patients with the IGF-1 levels below the 25th percentile, intermediate IGF-1 levels between 25th to 75th percentile, and the patients with high IGF-1 levels above the 75th percentile. So coming to the results, in our study, 60% patient had the sarcopenia, and patients with sarcopenia had significantly low IGF-1 levels compared to the others. And on the linear regression, we found a positive association of IGF-1 with the skeletal muscle index, and this association was significant even after adjusting for age, gender, BMI, and the MEL score. And we found no association of growth hormone with the sarcopenia. Coming to the frailty, we found a negative correlation of IGF-1 with the liver frailty index, and the frail patient, although not significant, they had a trend toward the low IGF-1 levels. Again, no association between GH levels and the liver frailty index was observed. 42% patient had osteodystrophy in our cohort. Among these, 35% with osteopenia and 7% with the osteoporosis. And the patients with osteodystrophy had low levels of IGF-1, and we found a negative association of IGF-1 with the osteodystrophy, which was significant even after adjusting for age, gender, BMI, and the MEL score. As expected, we found a negative correlation of the IGF-1 with the severity scores. In the complications, patients with increasing ascites grade had the low IGF-1 levels, and patients with low and intermediate IGF-1 levels had high prevalence of hepatic encephalopathy compared to those with high IGF-1 levels, and we found no association between IGF-1 levels and the complications at enrollment. We also observed the development of the complication during the 90-day follow-up, and we found that patients with low IGF-1 level had high cumulative incidence of development of complications compared to those with high and intermediate IGF-1 levels. Similar trend was observed at 180-day follow-up. With the prognosis, patients with low IGF-1 had significantly low cumulative survival compared to those with low and intermediate IGF-1 levels at 90-day and at 180-day. Discriminative ability of IGF-1 was comparable to the MEL score to predict the mortality at 90-day and 180-day follow-up. and adding IGF-1 with the MELD NA score further improved the discriminative ability to predict the 90-day and 180-day mortality. Next, we assess the dynamic changes in GH and IGF-1 level at 90-day and explored their association with the development of complications at 180-day follow-up. And we found that patients with high delta changes, that is improvement in the IGF-1, had low development of the complications, specifically for the ascites and infections, and prognosis and survivors, 180-day survivors had significantly high delta changes compared to the non-survivors, and percentage delta changes could predict the 180-day mortality with a good discriminative ability. So major finding of the studies are we found a negative correlation between IGF-1 levels with sarcopenia, frailty, osteodystrophy, and disease severity. Development of the complication and mortality during the follow-up was high among patients with low IGF-1, and this was further supplemented by the dynamically increased IGF-1 levels among the survivors. Just to summarize, how does GH and IGF-1 work? GH has direct and indirect effects. Directly, it enhances the liver regeneration. Indirectly, it acts through its downstream mediator IGF-1, which improves the muscle protein synthesis, modulates the osteoblast activity, and preclinical studies have shown the antifibrotic and anti-inflammatory action of the IGF-1. Taken together, GH and IGF-1 has anabolic and growth promoting and hepatoprotective effects. So implication of the studies are we found a multifaceted role of IGF-1 in the cirrhosis progression and its potential as a prognostic marker for predicting mortality in cirrhosis. Our study underscored the relevance of IGF-1 in predicting the development of specific complications in cirrhosis, and also dynamic improvement in the IGF-1 levels among patients who were surviving at follow-up highlights a strong potential for therapeutic manipulation of IGF-1 in cirrhosis. And at last, I would like to extend my gratitude to the INASL for giving me this opportunity, Department of Hepatology PGI, my guides, and my team. Thank you.
What is the way forward from here? If we measure the IGF-1 levels, how is it helpful for the patient?
Ma'am, it is helpful. First, IGF-1 levels could predict, had a discriminative ability to predict the mortality, 6-month mortality, and it was comparable to that of the MELD score. If it is validated in the multicentric studies, it can add to the prognostic relevance. Second, IGF-1, GH IGF-1 axis can be modulated by the administration of subcutaneous growth hormone, and Dr. Singh has already conducted a study on RCT in which they have seen the significant improvement in the sarcopenia after the administration of the growth hormone.
Only low IGF we should be giving growth hormone?
No, ma'am. We should start with growth hormone administration in patients with decompensated cirrhosis, and we should titrate the levels of growth hormone based on their response, how they are responding to the growth hormone administration. It will be based on the levels of IGF-1. With the administration level of IGF-1, if they are increasing, it means the patient are showing good response. So dose titrated GH administration can be a good therapeutic manipulation. Yes, sir. Sir, we are conducting a RCT on administration of growth hormone on the multiple to explore its association on the multiple axes, and we are starting with a low dose of 2 international units per day, and it will be given for the duration of 1 year, 2 international units per day for 1 year.
SMR and all those things. What are the various parameters you are going to take into account to assess the response of standardization of IGF therapy, the point 14 to 21 days of therapy?
The dose response will be seen first based on the IGF-1 level. If it is matching the age and gender-based preferences, the target is to achieve mid and upper limit of the normal range. And second, it will be titrated. It is titrated based on the prevalence of the side effects. If the patients are not having side effects and the response is less, doses can be increased.
Founders, when you measure IGF-1, what other things will influence the levels?
Other things that can impact the IGF-1 level will be the if we are measuring it in the fasting state or in the fed state, and others are the it will be dependent on the age, because the IGF-1 levels varies decreases with the age, and other confounders are the with the sarcopenia also the patient may have low IGF-1 levels.